So can you see my screen?
Yeah, but it's not showing anything right now. Yeah.
Assalamu alaikum, everyone. Thank you so much uh, to all the people who have organized this training program, and I would like to appreciate all the organizers and volunteers of giving back to pharmacy in Pakistan, who have done a tremendous job in organizing this second season of BCPS preparation. So myself, Ghulam Mujtaba, I'm working as Assistant Manager Clinical Pharmacy in Shaukat Khanum. So my major area of work in clinical pharmacy is critical care, acute care, internal medicine, infectious diseases. So I'm also working as a preceptor in critical care and palliative medicines. So before starting today's topic, I would like to disclose that I haven't received any financial funding or any aid, or I will not discuss any investigational drugs or any brands, or will promote any investigational product. So firstly, to understand the basic concepts of electrolytes, we should know that how the fluid in the body is distributed. So this total body fluid is to 60% of this total body fluid is intracellular. It means 60% of the entire body fluid is in the cells. It is enclosed in the cell membrane. So out of the remaining 40%, 75% is interstitial. That means this fluid is between the cells and the intravascular space. So remaining 25% is intravascular, and that is about 5 liters of the blood volume. So as you can see here in this picture, these yellow spots, they are intracellular fluid compartments. Similarly, the blue ones are the interstitial fluid compartment, and this fluid is, continuously bathing the body cells. And this red one is plasma, which is intravascular volume, which is around 5 liters. And this intravascular volume is very important for understanding of hemodynamics and other very important concepts for today's lecture. So how the fluids are divided? So fluids are divided into two broad categories: crystallites and colloids. So what are crystallites? So crystallites are fluids that contain water, sodium, and in addition to that, they have some other electrolytes. For example, lactated bringer has lactate, potassium, and calcium in addition to sodium and chloride. Similarly, normosol or plasmalite, they are also crystallites, and they have acetate, potassium, and magnesium in addition to sodium and chloride. So dextrose water is also a crystallite, but from a resuscitation point of view, this is very poor choice. This comes at the very bottom line of the line of resuscitation fluids. So why is that? Because when we look at the dextrose water, it is metabolized into water and carbon dioxide, and 60% of this the entire fluid that we give in the form of dextrose water, 60% distributes into the intracellular space and 40% to the extracellular. And out of that 40%, 25%, only 25% remains intravascularly, and 75% distributes into the interstitial space. Now remember, for resuscitation point of view, we need the fluid inside the vessels. That fluid matters during the resuscitation. When we give 1 liter of dextrose water, it metabolizes and only 100 ml remains intravascularly. So that makes this fluid a very ineffective choice for resuscitation. So what are colloids? Colloids are too large to cross the capillary membranes, therefore they remain primarily in the intravascular space. So this makes them very effective, but at the expense of cost. Mostly colloids, they are very expensive. For example, albumin is very expensive as compared to the traditional crystallites that we have discussed in the previous slides. So what happens when we give colloids? For example, when we give albumin, 5% albumin, uh, when we give 500 ml of 5% albumin, it replaces 1:1 inside the vessels. When we give 500 as resuscitation fluid, it replaces 500 inside the vessels. So but that is different in case of 25% albumin. 25% albumin acts as plasma expander, and when we give 100 ml of albumin intravenously, it expands the plasma 5 times and it replaces the intravascular volume 5 times. So if we give 100 ml, it will replace intravascularly 500 ml. It will draw fluid from the extravascular space, which is interstitial fluid. So similarly, hydroxyethyl starch and dextran, they are also colloids, but they are not being used due to their issues of coagulopathy and kidney impairments. So nowadays, dextrans are rarely used, and the most common indications for their use in acute care is dengue hemorrhagic shock or overall hemorrhagic shocks. So now we have a case. A 65-year-old man who has a 3-day history of body temperature of 102, lethargy and productive cough, is hospitalized for community-acquired pneumonia. So his medical history include hypertension, which was uncontrolled coronary artery disease. His vital signs include heart rate of 104, blood pressure of 112/68, which is almost normal, body temperature of 101, patient is febrile, his urine output is 10 ml per hour, which is very less. Potassium is normal, BUN is high, serum creatinine is high, and white count is normal. So other lab values are normal. So which is most appropriate at this time? So remember, from exam point of view, this is very important that while we are sitting for the exam, we must rule out the choices that have a probability of being least correct or being very incorrect. For example, when we look at this case, this patient is dry. Patient is in renal failure due to hypoperfusion. It means the patient is dry, intravascularly dry. And when we further diurese this patient, this is going to further cause kidney damage, further make the patient intravascularly dry, and make the end organ damage more pronounced. So we can't diurese this patient. So furosemide option A is very incorrect. And when we look at the option D, which is dextrose water with half saline, as we discussed earlier, dextrose water is a very ineffective choice for resuscitation point of view. So we can't give that as well. Similarly, remember one thing more. For resuscitation point of view, the fluid should be given in the form of boluses, and that fluid should be given rapidly, not at a defined rate or a preset rate of 100 or 200 ml per hour. So option A and D are incorrect. So when we look at option B and C, both of them, they are, one of them is colloid and another is crystallites. So albumin is very costly. So there are very few indications of albumin, and we really use albumin as a resuscitation fluid because of its cost. And there are various studies that have shown that when we compare albumin with saline, are when we compare colloids with crystallites. So colloids doesn't have mortality benefit. So this makes them down the line. So in this case, lactated bringer, which is option C, is the right option. So off note, one of this trial is a safe trial. This trial compared albumin with saline. So this was a very a well oriented and very well designed study. It was done in different centers. It was multi-center. And when they compared the result, so the odds ratio of two groups, it was 0.99. So this makes them, pretty comparable. So there wasn't any mortality benefit of giving colloids. So colloids are expensive, so they are down the line for resuscitation. So where fluid resuscitation is indicated? It is indicated in all the patients who have signs and symptoms of intravascular volume depletion. So when we look at the data, what are the signs and symptoms of intravascular volume depletion? So the patient have physical signs of cold and clammy skin. Patient have dry mucous membranes. Patients may have end organ damage, like in the previous case we discussed, patient had kidney damage, and that was due to intravascular volume depletion, which results into hypoperfusion and then kidney damage. So what is the goal of fluid resuscitation? So the goal of fluid resuscitation is to restore the intravascular volume and to prevent the further organ hypoperfusion. So remember, intravascular volume determines the amount of the fluid or amount of the blood that is ready to be ejected at the end of the diastole, which is preload. So preload determines stroke volume determines cardiac output, and cardiac output determines blood pressure. So if the stroke volume is less, so cardiac output will be less, and ultimately the blood pressure will be less, and which causes hypoperfusion and end organ damage. So intravenous fluids, they are administered in the form of boluses, as we already discussed. So different institutes have their different protocols. Some of them, they give them in the form of boluses, and some organizations, they give weight-based. So the usual weight-based dose is 30 mils per kg, and that is given rapidly in the form of boluses. So in a patient who has 70 kilos of weight, 30 ml per kg, it makes this volume around 2000 ml at 2 liters. So as we discussed, we have two crystallites which are cheaper, and they are as effective as colloids. One is lactated ringer, another is sodium chloride. Because plasma light 148 is very expensive, so it is not available in most of the resource limited countries. Like in our country, we don't have plasma light. So what should be the fluid of first choice? Lactated ringer or saline? So this is a very debatable thing, and there are various studies available who have shown that lactated ringer or the balanced fluid regimens, they have low incidence of acute kidney injury as compared to the saline. So what is wrong with saline? So saline has a very high amount of chloride, so 154 per liter. So as compared to lactated ringer, which has 95. So what happens? So this causes hyperchloremia. This hyperchloremia causes hyperchloremic metabolic acidosis, and that further damages the kidney. So in another multi-center retrospective cohort study, a balanced solution compared with isotonic fluid in patient with sepsis who had vasopressor dependent sepsis, those who received balanced fluids had low risk of in-hospital mortality. So another recent study which was done which was published in 2018 in New England Journal of Medicine, it showed that patient when we compare 0.9% saline with the with the balanced crystallites, uh, for example, lactated bringer solution. So the early we start balanced crystallites, especially in the triage, those patients who had early resuscitated with the balanced solutions, they had lower composite outcomes of any cause of death. They had lower incidence of kidney damage, and the need for uh, reduced need of renal replacement therapy, you can say, and they had lower incidence of renal dysfunction in the intensive care unit, although there was no difference found in hospital-free days in non-ICU patients. So when we look at the guidelines, especially this topic will be very well covered in the upcoming lecture which we have on the next weekend on 29th in critical care. So now the fluid choices between ringer and saline. So the guidelines recommend to give a very balanced amount of both of these solutions. So we have already discussed that colloids are not superior to the crystallites, and crystallites are the answers to many questions. So what are the choices for maintenance and how the maintenance fluids are calculated? Most of the organizations, they have their own formulas. Some of the organizations are institute, they give maintenance fluids weight based, and some of them, they have some formulas. Most commonly formulas is the one that is written here in this slide and your workbook as well. So what you actually do is you give 100 mils per kg for first 10 kg, and then you give 50 mils per kg for next 10 to 20 kg. So if a patient has a weight of 20 kg, it will make the maintenance fluid around 1500 ml. So any weight above 20 kg, you add up 20 mils per kg for every kg greater than 20 kilos. So now we have our first electrolyte, which is potassium. Potassium is very important. Normal range of potassium is 3.5 to 5. So any value of potassium below 3.9, serum potassium below 3.9 is hypokalemia, and any value above 5. In some institutes, they have upper limit of potassium, which is 5.2 or 5.3. So if they have above 5.2, that is hyperkalemia. So this potassium is primarily intracellular cations. It means the more potassium is inside the cells as compared to the extracellular. So there are two important factors which they help in balancing this potassium shift between the intracellular compartment and the extracellular compartment. One is beta-2 adrenergic stimulation, and another is insulin. So what happens in hypokalemia? So patient might have reduced intake. For example, the patient has been somehow nothing but oral, or somehow the patient patient was not taking adequately through the oral route. So this is one of the main reasons for hypokalemia in malnourished patients. Second factors, there are multiple factors which can cause the shift of potassium inside the cell. It means they push the potassium from extracellular space to the intracellular compartment. So one of them is alkalosis, another insulin. So when we give insulin, it causes hypokalemia. How does it cause hypokalemia? It pushes the potassium inside the cell. Similarly, beta-2 receptor stimulation, it does the same. Patients who are hypothermic, they usually have hypokalemia. Patients who have GI losses, they have hypokalemia. Patients who have urinary losses, they have hypokalemia, especially in mineralocorticoid excess. So remember, this is very important. The last point is very important from your practice point of view. Whenever you have a patient with hypokalemia, always remember to check for levels of magnesium. because if the patient has concurrent hypomagnesemia, this will make the potassium replacement very ineffective. Because so why is that? Because the magnesium uh, inhibits the renal outer medullary potassium channels. So these channels, they secrete the potassium out of the renal tubules. So if in the presence of adequate magnesium, these channels are inhibited. And when the magnesium level is quite low, these channels are no longer inhibited, and they are activated in the presence of hypomagnesemia. And what they do, they start throwing potassium out of the renal tubules, causing further hypokalemia. So in patients with hypomagnesemia and hypokalemia, always remember to replace magnesium alongside potassium. So what are the symptoms of hypokalemia in patients? Initially, the signs and symptoms are usually muscular weakness, and it starts from the lower extremities, and then it can progress to the upper trunk, upper extremities, respiratory muscles. And some patients who have a severe potassium deficiency, they might present with a paralytic ileus, abdominal distension, nausea, vomiting, constipation. This muscle weakness is very pronounced. We had one patient who had a potassium level of 1.8 at home. This patient, when presented, he had ECG changes. He had very pronounced muscular weakness. And when you replace potassium, this muscular weakness, it is reversible, and patient, they regain their strength within within the next 24 or 48 hours of replacement. So when you don't replace potassium, what happens? Patient might have cardiac arrhythmias, bradycardia, heart block, ventricular tachycardia, ventricular fibrillation, and cardiac arrest. So another very important thing is, for those patients who are on the digoxin and they have ongoing potassium loss and have hypokalemia. So for the time period that they had hypokalemia, their digoxin doses should be held, because hypokalemia can cause digoxin toxicity despite of the normal digoxin concentration. So always remember to check the potassium levels in patients who are on digoxin and they have ongoing diarrhea or any GI losses. So this they can present with acute toxicity of digoxin. So how do we treat hypokalemia? So in patients, usually we start with the oral potassium. In patients who are asymptomatic, we give oral supplementation. And in patients who have symptoms, we give it through the intravenous route. So there are some points that needs to be considered when we are replacing potassium. So avoid mixing potassium in the dextrose, because if you give it alongside the dextrose causes release of insulin. Insulin will shift the potassium inside the cells. This will further result into hypokalemia. So avoid this combination. Do not dilute potassium in dextrose. So to avoid irritation, no more than 60 to 80 milliequivalent per liter should be administered through a peripheral line. And in patients who require very high replacement, or in whom the ECG changes are very pronounced, or recurrent ECG changes, that those patients, they should be admitted in the intensive care unit. They should have a continuous ECG monitoring, and the replacement should be continued with 10 to 20 MEQ per hour through a central line. The maximum rate is 40 milliequivalent per hour. Hyperkalemia. So what happens in hyperkalemia? So patient can take more potassium in the, there are certain diets that have very high amount of potassium, like bananas, dates. They have very high amount of potassium. So shift of potassium from intracellular to extracellular, as we discussed in case of hypokalemia, so the reverse happens here. So what happens that the patient, that the potassium moves from intracellular to the extracellular compartment. And there are some conditions that can cause hyperkalemia, like acidosis, insulin deficiency, beta adrenergic blockade, digoxin overdose, rewarming, especially after hypothermia, succinylcholine, succinylcholine, and all those patients who are, uh, who are paralyzed with succinylcholine. Always remember to check for the potassium levels. If the patients have very high level of potassium, don't try and do not give succinylcholine. So another important factor is decreased urinary excretion, which can happen in case of kidney function, intravascular volume depletion, hypoaldosteronism, potassium diuretics. They can cause hyperkalemia. Similarly, ACE inhibitors, ARBs, they all can cause hyperkalemia, and trimethoprim, which is present in in cotrimoxazole along with sulfamethoxazole. So this can cause hyperkalemia, and certainly we had number of patients who developed hyperkalemia with this drug. So what are the symptoms of hyperkalemia? Similarly, muscle weakness or paralysis, and neuromuscular, because of the changes in neuromuscular conduction. When the potassium level goes above 8 milliequivalent per liter, it can cause the cardiac conduction abnormalities. It can cause the ECG changes, widening of the QRS, and due to widening of the QRS, it can lead to ventricular fibrillation, asystole, and cardiac arrest. So this is a medical emergency. This should be taken very seriously. This should be treated very immediately. So in all those patients who have symptomatic hyperkalemia, they should be treated immediately. So how do we treat? So all those patients who have a potassium level of more than 6.5, who have muscle weakness or ECG changes, they are the patients who should be treated immediately. So how do we treat? All these patients who have symptomatic hyperkalemia, they should be given calcium. So there are two dosage form of calcium. One is calcium gluconate, another is calcium chloride. So most of the organizations, they have calcium gluconate. So 1 gram of calcium gluconate should be given over 10 minutes. This calcium gluconate, remember there are some errors. This calcium chloride, if you have calcium chloride in your institute, remember calcium chloride should always be given through a central line. And also remember that calcium chloride had 3 times more elemental calcium as compared to the calcium gluconate. And always try to look for the dosage form and always give the correct dosage form. So first, in case of hyperkalemia, where the medical emergency, where the patient is in the emergency room or in the acute care unit, so insulin is the first choice, and it is one of the very effective emergency treatments for hyperkalemia. So we give insulin, and when we give insulin, patients, they will develop hypoglycemia. So to overcome that, we always give insulin along with dextrose. So in our hospital, we have 25% dextrose, and we give 100 mils of 25% dextrose. But in your hospital, if you have 50% dextrose, you can give half of that volume. So it lowers the potassium by 0.5 to 1.5 mQ per liter within the first hour, and this effect remains for the many hours. Remember, all those patients who have hyperglycemia at the baseline, do not give insulin with dextrose. Give just the insulin. Although the hypoglycemia might occur, but always check for the signs and symptoms of hypoglycemia when you give insulin. The second choice is sodium bicarbonate. It is very rarely used in our setup. If I tell you the truth, we use it very rarely. We use it during the course situations when we know that the patient might have hyperkalemia, especially in patients who have tumor lysis syndrome. They usually present with the hyperkalemia induced ECG changes, and then they might have arrest at some point of their time. So in all those patients, we give sodium bicarbonate. The third strategy is to give the beta-2 adrenergic agonist, which is albuterol or salbutamol. So 10 to 20 milligram in the form of nebulization should be given over 10 minutes. So some people, they give in albuterol inhalers, and they give very low doses of albuterol. That is not quite effective. Even when you give it in the recommended doses, only about 40% patients, they respond to this inhaled albuterol. So do not, in patients who have life-threatening hyperkalemia, do not give the beta-2 adrenergic agonist as the only treatment. Always combine this strategy with insulin or either bicarbonate. So all those patients who have a baseline coronary ischemia or who have a baseline any cardiac dysfunctions, try to avoid use of beta-2 adrenergic agonist in these patients because they might have tachycardia. So diuretics again is a ineffective way of reducing potassium, and the very effective way of reducing potassium is to give the cation exchange resins, which is sodium polystyrene sulfonate. It exchanges sodium and absorbs potassium, so it is excreted from the body. So there are some limitations with the use of sodium polystyrene sulfonate because it has very slow onset. You cannot give it for the emergency treatment of hyperkalemia because it will take 2 hours, and obviously your patient with hyperkalemia of 8 cannot take 2 hours. So oral doses of sodium polystyrene sulfonate is 15 gram, and it should be repeated every 6 hours. So initially we used to dilute it with 70% sorbitol, but there were some case reports of intestinal necrosis with this combination. So this is no longer recommended that sodium polystyrene sulfonate should be diluted in sorbitol, 70% sorbitol. So there are some newer drugs which have been approved for as a exchange resins for the treatment of hyperkalemia, and one of them is Paterometer. And the benefit it offers as compared to the sodium polystyrene sulfonate is that it exchanges calcium instead of sodium. So you won't have problems of fluid overload and hyponatremia. So it is safe to use in patients who have heart failure. Similarly, another new drug, which is sodium zirconium cyclosilicate. It was recently approved, and it works by exchanging potassium for hydrogen and sodium. So dialysis is the last resort. So in patients, all those patients who have refractory hyperkalemia to all those measures that we have discussed in the previous slides, they should be dialyzed. And the better strategy for dialysis is intermittent hemodialysis, not peritoneal dialysis, because you need to immediately remove the potassium from the body. So it is very effective in patients who have advanced kidney disease. Next comes the calcium homeostasis. So normal serum calcium level is 8.5 to 10.5. So any level below 8.5 is hypocalcemia, and any level above 10.5 is hypercalcemia. So there are two important factors that we need to understand before we discuss the management and signs and symptoms of this calcium disorders. One is extracellular fluid contains less than 1% of the total body stores of calcium. 99% of your total body stores of calcium is in the skeletal bones. So about half of the calcium in the extracellular space, which is, only 1%, it is bound to the plasma proteins, primarily albumin. So the active form of calcium is the unbound or the ionized calcium, which is not bound to the albumin. So ionized calcium is regulated by parathyroid hormone, phosphorus, vitamin D, and calcitonin. So always, try to remember all these factors when we are, going to interpret the calcium levels in any patient. So what happens in hypocalcemia? So it can happen in patients with chronic kidney disease because they have a vitamin D deficiency, and vitamin D deficiency can cause hypocalcemia. Hypoparathyroidism, alcoholism, hypophosphatemia, patient receiving large amounts of the blood products, patients who are dependent on the blood products, patient undergoing continuous renal replacement therapy, because one of the anticoagulants that we use in CRRT has acetate. That acetate, it absorbs calcium and takes it out of the body. So factors that cause an increase in extracellular calcium binding to albumin. One of them is metabolic alkalosis. It can cause reduction in the plasma ionized calcium concentration, leading to symptomatic hypocalcemia. So always check albumin levels and always calculate corrected calcium levels before you start the replacement. So what are the signs and symptoms of hypokalemia? So in our setup, we usually see the symptomatic hypocalcemia in patients who had total thyroidectomy, because in all those patients, thyroid function, is lost. And then the patients, they remain on calcium replacement for their entire life. And if those patients, they have a compliance issue, somehow they stop taking their medicines as advised, so those patients, they present with symptomatic hypocalcemia. So what happens in hypocalcemia? Those patients may have tetani, muscle spasm, hypoactive reflexes, anxiety, hallucination, lethargy, hypotension, and in very severe cases, those patients might have seizures. So what is the treatment? So remember, if the patient is asymptomatic, in any case, whether you have hypokalemia, hypocalcemia, or hypomagnesemia, if the patient is asymptomatic, always try to give the oral replacement. Similarly, in case of hypercalcemia, if the patient is asymptomatic, always give oral calcium, because the oral calcium contains more elemental calcium as compared to the IV form, which is calcium gluconate. So 1 gram of calcium gluconate contains around 91 milligram, and 1 gram of oral calcium contains, which is calcium carbonate, it contains around 500 milligram of elemental. So this oral replacement is very effective in patients who are asymptomatic. So in symptomatic hypercalcemia, they are treated with 200 to 300 milligram of elemental calcium. So some institutes, they have their protocol for the replacement of calcium in symptomatic patients. Like in our settings, we have a protocol which we follow for these patients. Remember, as we discussed, there is difference between calcium gluconate and calcium chloride. Calcium chloride should always be given through a central line. That is a very, very serious error if you give the calcium chloride through the peripheral line. So disorders of phosphorus. So normal phosphorus concentration is 2.5 to 4.5 milligram per dl. So hypophosphatemia, all those patients who have less than 2.5, they have hypophosphatemia. So what are the causes of hypophosphatemia? If the patients, they have increased renal elimination, like the patients are on diuretics, they are taking glucocorticoids, sodium bicarbonates, all these drugs can cause hypophosphatemia. Similarly, patients who are in refeeding syndrome, and the patients who present with diabetic ketoacidosis, because the phosphorus shifts into the intracellular compartment in patients with diabetic ketoacidosis. So what are the signs and symptoms? So remember, your phosphorus in the body is very important. All of the energy functions which require ATP, they are almost always regulated by the phosphorus level. Similarly, your oxygen carrying capacity is also phosphorus dependent. In patient who have a very low phosphorus, those patients, how do they present? The patients may have tissue hypoxia because of the decrease in oxygen released to peripheral tissues, because you require at the uh, when you look at the oxygen dissociation curve, you need phosphorus at the very last step. So similarly, those patients, they have neurological manifestations including confusion, delirium, seizures, and coma. And pulmonary and cardiac symptoms, they may include respiratory failure, difficulty weaning from the mechanical ventilation, heart failure, and arrhythmias. So other organs include muscles, hematological, bone, and kidneys. So this is very important electrolyte in our daily practice. So how do we prevent hypophosphatemia? We give supplemental intravenous fluids with phosphorus. So there are some risk factors which can cause hypophosphatemia, like the patients who are malnourished, they might have hypophosphatemia because at some stage of the uh, treatment, they may go into refeeding. Similarly, patients who are alcoholics, they have this hypophosphatemia, and they also are on a high risk to develop refeeding syndrome. Diabetic ketoacidosis. So our oral phosphate products, like we have Julie solution in our hospital, we usually give it to the asymptomatic patients, but that is very poorly absorbed. So in symptomatic patients, you require the IV replacement. So IV replacement is from 0.5 to 0.75 millimoles per kg of idle body weight, and that should be given very slowly, because most of the phosphate preparations, they contain potassium along with phosphate, and they should always be given cautiously because of their potassium content. So what are the strategies that we can adopt in case of phosphate shortages? We can reserve the phosphate for the critically ill patients, like the ICU patients, or the patients who are on a very high risk for developing hypophosphatemia, like the patients with refeeding syndrome, ketoacidosis, children, neonates, and diabetics. Similarly, intravenous fat emulsions, they contain phosphorus, which is 15 millimole per liter as egg phospholipids. And in patients who are on intravenous fat emulsions, are on TPN, if you do not give additional doses of phosphorus, it may be sufficient in some patients. What are the disorders of magnesium? So normal magnesium level is 1.7 to 2.3. So usually the hypomagnesemia is associated with impaired intestinal absorption, which can happen in patient with ulcerative colitis, diarrhea, pancreatitis, chronic laxative use, and in patients who have inadequate intake of magnesium. Similarly, in patients who have ongoing hyperkalemia, they have concurrent hypomagnesemia, as we discussed earlier, and patients who have renal failure are on diuretics. So what are the signs and symptoms? Neuromuscular symptoms may include tetany, twitching, and seizure. Cardiovascular symptoms are arrhythmia, sudden cardiac death, and hypertension. Similarly, So how do we treat hypomagnesemia? All those patients who are asymptomatic, they should be given oral potassium. But this oral magnesium, my apologies. The limitation of oral magnesium is the association of diarrhea along with the oral preparations. So if you give too much of magnesium orally, it can cause diarrhea, and that diarrhea will further uh, through the magnesium out of the body. So in those patients, then you at some stage of treatment, you may require IV replacement. So symptomatic patients, they should be treated with 1 to 4 gram of magnesium. That magnesium should be given very slowly, because with the rapid administration of magnesium, the clearance, the more rapid you give it, the more rapid it is excreted from the kidneys. So the strategy is always to replace the magnesium slowly over a couple of hours, and then you check the magnesium levels in next 24 hours, because the replacement takes time. So now we have another case, a 72 years old woman, weight 60 kg, with history of hypertension. She has developed hyponatremia after starting hydrochlorothiazide 3 weeks earlier. So she experiences dizziness, fatigue, and nausea. Her serum sodium is 116 mg per liter. Her blood pressure is 86/50, and heart rate is 122 beats per minute. In addition to discontinuing hydrochlorothiazide, which initial treatment regimen is best? So what is the right option? Administer 0.9% sodium chloride at 100 ml per hour. The green one is option B, administer 0.9% sodium chloride, 500 ml bolus, administer 3% saline, and administer 23.4% sodium chloride. So what is the right option? So when we look at the case, this, as we discussed earlier, the patients who have signs and symptoms of hypophosphatemia and intravascular volume depletion, they should always be resuscitated with the fluids, and the intravascular volume depletion should be corrected first. Because what happens in all those patients who have hypovolemic hyponatremia, the volume replacement always should be done initially, and then the sodium it starts coming up. So in case this serum sodium is 116, but the patient is hypovolemic, as her blood pressure is 86/50 and patient is very tachycardic, this shows that the patient is dehydrated. So what is the right option? So as we discussed, we always give the fluid for resuscitation in the form of boluses. So option A is not the right option, which is 100 ml per hour, and this replacement will take time. Similarly, in all these patients, there are very limited indications of 3%, which we will discuss in the upcoming slides. Very limited indications of 3% and 23.4%. So that those preparations, they can cause rapid shift of the rapid replacement of this sodium, which has its own drastic consequences. So in this case, option B is the right option. So let's discuss this one. So due to the time limitation, I will not go into the details of osmolality. I expect you to know the difference between the osmolality and the osmolarity, and how that is regulated inside the body. So if you have any question, you can ask me right away, but I won't go into the details. So what happens in hyponatremia? So any sodium level above 145 is hyponatremia. So what happens? The osmotic gradient associated with hyponatremia causes the water movement out of the cells. out of the cells and into the uh, extracellular space. So these symptoms are related primarily to the dehydration of brain cells. So causes of hyponatremia. So as we discussed earlier, if you lose too much of a water, then you know what happens. The sodium will be concentrated. So patients, these patients, they have hypovolemic hyponatremia, and there are some medical conditions which can cause the loss of water from the body, like fever, burns, infection, and the renal loss. Similarly, retention of sodium because of the administration of hypertonic saline or any form of the sodium chloride. Some patients, they, you know, they, the you know, physicians sometimes start them on the sodium chloride and they just forget to discontinue the sodium chloride, and the patient, you know, on the third day, when you look at the sodium goes above 150, and then you know, you really you realize that the patient has been on the sodium chloride for the previous couple of days. The third cause may be the certain neurological injuries, for which we give hypertonic saline. So how do we prevent hyponatremia? So plasma osmolality is maintained at 275 and 298. So when you have high sodium level in your body, you know, you have a thirst center, and you know, you feel that you should have plenty of water. And because, you know, hyponatremia is prevented by release of ADH, which, you know, causes the water reabsorption, then your hyponatremia uh, uh, will also be prevented by the thirst. This limitation, you know, is a very challenging in the patients who have reduced conscious level and who cannot you know, verbalize the thirst, or who cannot tell that they are thirsty because of their medical conditions or and some neonates. So hyponatremia occurs primarily in adults with altered mental status who have an impaired thirst response, or who do not have access to the ability to ask for water. So hyponatremia can also occur in infants, as we discussed. So what happens? So at some point of time, you know, brain, you know, brain has very executive functions. So at some point of time, the brain cells, they start to adapt this high sodium level. So what happens? They start uh, they start taking sodium into the cells. You know, that will you know, balance the situation between the intracellular and the extracellular compartments. So that osmotic, you know, adaptation is a natural phenomena in these patients. So symptoms, what are the symptoms of hyponatremia? They can start from the twitching, they can progress to seizures, coma, and death when the patient when the sodium level goes above 158. So mostly symptoms of hyponatremia and hyponatremia, both of them, they are neurological. Treatment of hyponatremia. So the treatment of hyponatremia is to give free water, because, you know, water is going to balance that thing. So the simple way is to calculate the water deficit. There are certain formulas which are available online. Similarly, these formulas are written in your workbook as well. One of this formula I have written in this slide as well. So you calculate the water deficit in liters, and then you divide it into different hours and start giving the patients. So the preferable choice for the water replacement is to give it orally instead of giving the dextrose water, because dextrose water has other issues in these patients. So it is always better to replace the free water orally. So hypertonic saline. Hypertonic saline has a concentration which is, you know, they are available in as 3%, 7.5%, and 23.4%. So common uses of hypertonic salines is is most commonly used in TBIs, where the patients, they have elevated intracranial pressure, and when you give it, it reduces the intracranial pressure. Similarly, hypertonic saline is used in patients who have symptomatic hyponatremia. So what are the symptoms of severe hyponatremia? They include comas and seizures. So in an effort to prevent severe symptoms from occurring, some practitioners treat asymptomatic or moderately symptomatic hyponatremia before serum sodium concentration reach below 120. So remember, most of the patients, in case of acute hyponatremia, they would have signs and symptoms of hyponatremia only when the sodium level goes below 120. So in those patients who might have symptoms, and those symptoms can complicate uh, their uh, their primary medical illnesses, in all those patients you can use hypertonic saline. So what are the inappropriate uses of hypertonic saline? So do not give, remember, do not give it in chronic asymptomatic hyponatremia. That is a big no for the use of hypertonic saline. Similarly, hypernatremia, which is associated with hyperglycemia. So that is a pseudo hypernatremia, and do not give 3% or 7.3% or 23% saline. That is a big no. Similarly, hypernatremia, which is associated with hypovolemia, as we discussed earlier, these patients should be given fluid first, and then if they have at some point of time, in when they are uh, adequately perfused, or you can say they have adequate uh, intravascular volume, and in spite of that they have hyponatremia, and that is a symptomatic hyponatremia, then you consider giving it. So in general, the hyponatremia in patients, uh, who have chronic hyponatremia, they are usually treated with fluid restriction. So symptomatic hyponatremia is uncommon in patients with heart failure. So hypertonic saline should be considered in symptomatic patients. However, they may also need diuresis. So remember, the heart failure patients, they are very volume sensitive. When you give hypertonic saline, it contains a significant volume, and then the patients they have volume overload, and at some point of time you have to diurese these patients. So hypertonic saline dose, in our setup we give it weight based, 2 to 4 mils per kg. It is given over 15 minutes. We do not have 23.4% or 7.5%. We just have 3%. So most of the hospitals, they have the institutional guidelines for the administration of hypertonic saline. But remember, hypertonic saline should always be given through a central line, because its osmolarity is greater than 900. So if you don't have a center line, then you can't give 3%. Then it is better to give 2% hypertonic saline. What are the goals of treatment in hyponatremia? Stop symptoms, save serum sodium. Always remember, there is safe target of sodium replacement, that is 8 to 12 milliequivalent per liter, and it should not be exceeded in 24 hours. Remember, it should not be exceeded. And when you have some case, so always try to remember this thing: you cannot replace more than 10 to 12 MEQ per liter in 24 hours. So monitoring of serum sodium is recommended every 1 to 4 hours, depending on the severity. And remember, when you have a patient who has hyponatremia, symptomatic hyponatremia, you have two goals. One, to prevent the symptoms, to stop the symptoms, and secondly, to avoid rapid correction of serum sodium. So what happens when you rapidly replace the when you have a patient in which you did somehow rapid correction of serum sodium? Those patients may have demyelination syndrome. That syndrome is very uh, you know, debilitating. That syndrome might cause permanent uh, disability in some patients. So hypokalemia can occur with the large volumes of hypertonic saline. Always remember, all the patients who are on hypertonic saline, always remember to check their potassium levels. Similarly, hyperchloremic acidosis, because you are giving too much of a sodium and too much of chloride, and that can cause hyperchloremic metabolic acidosis. Phlebitis, if you give it through the center line. Heart failure, they are volume sensitive. We have already discussed. There is always chance that those patients might have volume fluid overload at some stage if we give too much of fluid. So coagulopathy, and which is caused by platelet dysfunction, hypertension, and hypokalemia should always be corrected along with hyponatremia, because this will make it, as we discussed for in previous slides. So we have our last topic of our today's lecture, which is nutrition. So what happens when you do not give nutrition? So as you can see in the picture, this patient has a malnutrition, which is quite evident from his facial features. Patient has a temporal bone, which is very clear. uh, Malnutrition is always associated with higher mortality in patients. So what are the strategies for nutrition? Either you give it, and all those patients who can't take it through the oral route, either you give it through the enteral route or you give it through the parenteral route. So firstly, we will discuss about the enteral route. So all those patients in which you expect that the patient won't be able to take orally for the next 7 days or more than 7 days, in all those patients, you need to start these patients on enteral nutrition. And if the patients have contraindications of oral route, for example, patient might have facial trauma, in all those patients, you need to start those patients on enteral feed. So patient at risk of malnutrition, if they can't take orally much, the recommended caloric intake through the oral route, then you supplement the oral route with the enteral nutrition. So in all those patients in which anticipated that the oral feeding will be inadequate for 5 to 7 days, you start the enteral feed within the 24 to 48 hours of ICU admissions. So what are the contraindications? If the patient has complete intestinal obstruction, if the patient has GI fistula, if the patient have short bowel, if the patient has severe diarrhea or vomiting, if they are hemodynamically unstable or intestinal ischemia, if the patient has paralytic ileus, if the patient, and what we have seen and what is, what we discuss in our patients, some physicians, they go to check the bowel sounds, whether the bowel sounds are present or not. If the bowel sounds are present, they start the patients on feed. So this is no longer recommended. And if the patient has absent bowel sounds, that is not a contraindication for the enteral nutrition. So there are two ways to give enteral nutrition. One is nasogastric tube, another is orogastric tube. And all those patients who are awake, who are conscious, you cannot put the tube inside the oral cavity, because that patient will be less compliant and the patient won't tolerate. So the better strategy in all these patients is to put a nasogastric tube. These are large bore tubes. They have dual purpose. one purpose is to give the feed. Another purpose, which is, in some circumstances, we give it, we put the NG to decompress the stomach. So the second strategy, the second thing is the small bore feeding tubes. They are very flexible, they are easy to put in, and but they have their uh, pros and cons, because when you give the feed through a small bore feeding tube, they usually become clogged. So you have to replace those again and again. So in all those patients who and which you expect that they are for a very long period of time, they cannot take orally, in all those patients, a better way to give the feed is through PEG tube, which is percutaneous endoscopic gastrostomy tube. So how do we deliver enteral nutrition? So there are different methods. One is gravity control, another is continuous feed, third is cyclic feeds, where you give the recommended caloric diet for 10 to 12 hours, and then you let the patient sleep overnight and then start this cycle again in the morning. Similarly, intermittent pulses, you divide the total caloric feed into different portions, and then you give it every 4 to 6 hours. So each one of these strategy has its own benefits, pros and cons. So what are the benefits of enteral nutrition? All these patients, they have less risk of infection, they would have less risk of complications. This is more natural way of feeding, and it can preserve the gastric motility. Remember, patients who are on the parenteral nutrition for a prolonged period of time, they have reduced gastric mortality due to due to atrophic changes in their intestine. So in our settings, we usually use 1 kilocal per ml of formula, but there are various formulas. When you look at the product label, you will know that what is the actual formula of that nutritional product. So all those patients who have somehow volume restriction, in all those patients, we give 2 kilocal per ml of formula. And in patients who doesn't have or the patients in which there is no fluid restriction, in all those patients we give 1 kilocal per ml formula. So what happens in renal failure? We'll give more concentrated fluid because we don't want additional fluid. Kidneys are not working, and that can cause fluid overload in these patients. So in respiratory failure, we'll give more calories from the fat. And remember, we do not overfeed these patients, because overfeeding can cause excess CO2 production, and that can prolong the mechanical ventilation time for these patients. Diabetes, they should be given less carbs and more fiber. Similarly, hepatic failure, they should be given branched chain instead of aromatic amino acids. High protein diet in patients with more stress factors, for example, the patients who present with the burns, are the patients who have other risk factors for malnutrition. All those patients should be given high protein diet. What are the enteral nutrition complications? You can put the tube, because it is a blind placement. Remember, you do not put it with the help of ultrasound. So instead of going into the stomach, the tube can go into the trachea. And this has happened when you look at the literature. So that is why most hospitals, they have their protocols. They always perform a chest x-ray whenever they put a OGR NG feed, NG tubing. So they usually become clogged due to larger particles of the food. There are always risks of aspiration, diarrhea, constipation, dehydration, hyponatremia. When you put it for a prolonged period of time, it can cause nasopharyngeal erosions, epistaxis, tracheoesophageal fistula, sinusitis, electrolyte abnormalities. So how do we monitor enteral nutrition? Blood glucose concentration, because you have to keep a balance. In all the hospitalized patients, the target blood glucose is less than 180 and more than 100. So head of bed elevation to 30 and 45 degrees, that will reduce the chances of aspiration. Similarly, GI tolerance, you check the physically the patient for abdominal pain or distension, stool frequency, the nausea, vomiting, or any gastric residuals. So in our hospital, our nursing staff, they are very well trained in this. So whenever they are starting patients on the feed, they always, they always check the nasogastric or the orogastric tubes for gastric residues. Pre-albumin, it is very debatable. In all critically ill patients, pre-albumin is usually low due to acute phase reactions. Serum sodium and other electrolytes. So if the patient had, for example, had a wound which is healing, it means the patient has been on adequate nutritional therapy. So I'll skip this case due to the time limitation because we are short of time and we have to take questions as well. So I'm skipping that case scenario for time saving. So drug administration, this is very important. As a pharmacist, we should know that. So liquids are preferable. The liquid dosage forms of the drugs, if you have, they should be diluted with the water, and always flush the tubes before and after the administration of the drug. Similarly, there are certain dosage forms that you cannot crush and put into the NG, like sustained release or enteric coated pills. Similarly, crush tablets, they should not be mixed with other dosage forms or other capsules or other drugs. So when you are going to give some drugs, the drugs which you have to take apart from the meals, like the fluoroquinolones, their concentration is significantly reduced if you give it along the feed. So what you'll do, you'll stop the feed 1 hour before the administration of the drug. You'll give the drug and then you'll start the feed 1 hour later. So how do we develop? As we discussed, there are two formulas. One is 1 kilocal per ml, another is 2 kilocal per ml. You calculate the total calories and then you divide this formula into different portions and give either in the form of pulses or in the form of continuous feeding. So now we have our last topic, which is parenteral nutrition. So what are the indications of parenteral nutrition? If the patient has severe pancreatitis, peritonitis, severe inflammatory bowel disease, extensive bowel resection, complete bowel obstruction, severe intractable vomiting or diarrhea, or inability to meet the full nutrition needs. So there are, when we look at the ASPIN guidelines, they suggest if the patient cannot take 70% of their recommended caloric intake, they should be supplemented with the parenteral nutrition. So what are the principles? So we have two types of preparations. One is two in one and 3 in 1. So in case of 3 in 1, you mix the 3 major components or the macronutrients within the same bag. And in case of 2 in 1 approach, you mix dextrose and amino acids and other electrolytes in one bag, and lipids are, they are given separately through a separate line. What are the nutritional components? 3 major components, which are macronutrients, dextrose, amino acids, and emulsions. So each one of them, dextrose gives 3.4 kilocalories per gram, fat gives 10 kilocalories per gram, and amino acids give 4 kilocalories per gram. So electrolytes are added to maintain the physiological serum concentrations, multivitamins and trace elements. These are the major components. So how do we develop? So there are 5 steps for the development of parental nutrition formula. So first of all, you'll calculate the caloric requirement. So there are 2 ways to calculate the caloric requirement. One is to just give it weight-based calories. So 25 to 35 kilocalories per kg per day, which is usual recommended caloric intake in critically ill patients. Another way is to calculate the calories through the indirect calorimetry, and third one is to calculate it with the use of some equations. For example, Harris-Benedict, which is a very famous equation. So you calculate the calories, then you calculate the fuel requirements. Thirdly, you calculate the protein requirements according to the medical condition that the patient has or had. Then you calculate the remaining non-protein calories. So how do we calculate these? We give 20 to 30% of the non-protein calories in the form of lipids, and the remainders are given as dextrose. So at the last, you calculate the total maintenance amounts of electrolytes, vitamins, and trace elements. So we'll discuss the order of mixing. Order of mixing is, is of considerations when you are manually compounding the TPN formula. Always remember to follow this order, because if somehow the TPN precipitates, then it has a very very major complication. It can cause thromboembolism. Mostly they cause pulmonary embolism. So what is the sequence? Always mix dextrose with amino acids. Remember, do not mix lipids with dextrose, because it will shift the pH and it will destabilize the lipid formulation. So we have to shift the pH towards the basic, right? So always, so amino acids help in this. So always at the very first step, always mix dextrose and amino acids first, then add sterile water if you have to, then add phosphorus. Now what will you do? You will add other electrolytes. For example, you'll give dextrose, D5NS or saline or other electrolytes, potassium, and then trace elements. The fourth step is to mix these gently and equally and evenly, and observe for any visible precipitation. And if you don't have precipitation, then you'll add calcium. Then again, you will observe for precipitation, and if the TPN precipitates, you'll discard it and then will formulate a new formula. So at the 7th step, you will add the lipids, and at the last you'll add the vitamins. So there are some factors which needs to be considered in order to reduce the calcium and phosphate precipitation. As we discussed, will increase the pH towards basic. The low pH destabilizes the lipids, and it can cause the precipitation. So the more you give calcium, the more calcium and phosphorus, the more is the risk of precipitation. Calcium, when given more than 6 MEq per liter, and phosphorus 30 millimole or more, then the precipitation risk goes up. Calcium chloride should never be given in the TPN formulas. Final concentration of amino acid should be 2.5%. Temperature, higher temperatures, they are associated with high risk of precipitation. So all those TPNs which are not intended to be given immediately, they should be refrigerated. And when you take them out of the refrigerator. Always remember to give them within the 24 hours. So another way to reduce the risk of thromboembolism is to use the 1.2 micron filter. Although it is not entirely effective in preventing the embolism, but it reduces the chances of developing embolism. So order of mixing additive, as we discussed, should be followed. PN should be agitated often during the compounding to ensure adequate mixture into the solution. So medication additives. So in my practice, I have a very general formula that we do not give any type of medication through the same catheter from which we are giving the TPN formula. But if somehow we have to give it, then we'll always check for the compatibility of that particular drug. There are certain drugs which are entirely incompatible with the TPN formulas, and they should always be looked for. So there, when you have to add regular insulin in the TPN formula, always remember that you will only give regular insulin. So what are the PN complications? Catheter related infections, catheter insertion complications, peripheral venous thrombophlebitis, fluid imbalance, acid base balance, hyperglycemia, as we already discussed, gut atrophy because the you are not feeding the patient naturally. You know, the atrophic changes in the villi, they reduce the motility, gut motility, and this becomes very challenging when you stop the TPN and start the patient on oral feeding. So overfeeding has its own drastic consequences like steatosis, hypercapnia, hyperglycemia, and azotemia. So do not overfeed. Essential fatty acid deficiency can occur in all those patients who do not have fatty acids in the TPN formula for more than 2 to 3 weeks. So it is always recommended to give the fatty acids every 1 or 2 weeks in the cases where you have lipid shortages. So you can have refeeding syndrome. So how to prevent this refeeding? So identify patients who are at the risk, as we discussed initially, patients who are anorexic, patients who are alcoholics, cancer patients, chronically ill patients, all of them, they are at high risk. So how to deal with these patients? In all these patients, always provide less than 50% of the calories, and then you escalate the calories over the next couple of days. Similarly, you start the patients on the vitamin supplementation and the potassium, phosphate, and magnesium supplementation, so that the hallmark of free feeding is hypophosphatemia, hypomagnesium, and hypokalemia, and that can be very dangerous, and it can result into cardiac dysfunction or cardiac arrest in some cases. So similarly, aluminum toxicity, hepatobiliary disorders. So that is why it is recommended to check regular LFTs of all these patients so that we know if the patient somehow develops steatosis, cholestasis, or gallbladder stasis, then we stop the TPN and we wait for the LFTs to return to normal, and then we de-challenge very carefully. Similarly, osteoporosis and osteomalacia in patients who are on the long-term TPNs. So how to monitor? So monitor for infections, monitor for peripheral line thrombophlebitis, monitor for fluid status, monitor for nutritional status. You can check the pre-albumin, but in critically ill patients, this is very challenging because the pre-albumin is usually low in patients who are in acute phase, like the patients of sepsis or septic shock. So the goal for malnutrition, you will also monitor for hyperglycemia, hypoglycemia. Usual blood glucose level is 140 to 180. So do not abruptly discontinue PN in patients who have been on long term on the TPN, because it can cause rebound hypoglycemia, especially in pediatric and neonate patients. This can be very dangerous, so always taper the TPN, and then when the oral route is very well established, then you discontinue it. Monitor for electrolytes and acid base, monitor for triglycerides, and monitor for hepatic function, monitor for patient readiness for oral or EN sport. So that is all for our today's talk of fluids, electrolytes, and nutrition. We had a limited time, और इसमें कोशिश की है आप लोगों को समझाने की. If you have question, please let me know.
जी अस्सलाम वालेकुम. जबरदस्त डॉक्टर गुलाम मुस्तफा, बहुत जबरदस्त लेक्चर, बड़ा मजा आया. So if there is any
Thank you so
question, you
much.
can share in the group. You can share in the chat box, please.
सर या तो बहुत अच्छी समझ आई है या बिल्कुल समझ नहीं आई.